Hi, everyone. We are going to get started. I wanted to introduce myself. My name's Jyoti. I work with Utiva. Some of you are familiar with Utiva, some of you probably are not. But we're really happy to have Dr. Inoyatov here today for an amazing talk on recurrent UTI management. Just a little housekeeping before we get started. So the webinar it is being recorded. The replay will be shared by the end of this week, early next week at the latest. You'll get it in your email, and the recording will be available indefinitely, so you can watch it yourself, share it with your colleagues. Any questions that you have, feel free to share them in the chat as they come up throughout the presentation. We'll make a note of all of them, and then at the end, we're going to allot hopefully 15 minutes to get through as many as possible. Any other question or any other things to note? I think that's about it. Um, we'll move into the presentation after the presentation, the Q&A, and then for anybody who's interested in the Amazon raffle, be sure to hang on because we will call your name live. So you'll just need to be here to raise your hand so we can save that for you. And then for anyone who's interested, we will do a product presentation on the product portfolio here at Utiva. If you're interested, you can hang on, and that's about it. So I wanted to introduce Dr. Igor Inoyatov. Thank you so much for joining us today. A little bit of a background on Dr. I. He is a board certified urologist at Z Urology in South Florida. He completed his medical education at SUNY Downstate Medical College in Brooklyn, followed by his urology residency at Stony Brook University Hospital. He is a member of the Alpha Omega Alpha Medical Honor Society, the American Medical Association, and the American Urologic Association. Dr. I specializes in female pelvic medicine and voiding dysfunction with a strong patient-centered approach and a passion for education, both with his patients and with medical students. So please join me in welcoming Dr. I as our speaker.
Thank you so much. Thank you. I want to thank Utiva's team for giving me this opportunity, and I want to thank everyone who decided to join us this evening. My talk is going to focus on really changing our perspective of looking at recurrent UTIs, looking at them as a frustrating, issue that our patients deal with and that we see in the office. Instead, to develop a framework around it so that we can really manage these patients in the primary care office. And I just want to empower you and your patients. So let's start. I want to look at the patient's perspective by just seeing, if you can relate to some of these quotes. I hear this all the time in my office. I'm sure many of you can relate, but our patients are frustrated when their antibiotics aren't ready. They think any symptom they have is a UTI because they've had so many of them. And if you don't care for them, then they'll go to an urgent care. And most of the time, they have a feeling when it's a UTI, they need another week of antibiotics. And most of the time, there's a stigma. They're really blaming themselves, asking if they should shower more or change their hygiene. However, there's the perspective of the physician, especially the primary care. So this was actually quotes from a qualitative study, a survey that was sent in 2024 to primary cares, asking them what are some of the barriers to treating UTIs. And these are quotes directly from primary care. Some of them had difficulty convincing patients to go to the office for urine cultures. Some of them only, went back and leaned back on what they learned in residency, but after that, they really haven't got enough training or learned anything since then. Many of them know simple techniques, telling their patients to clean front to back or not back to front, and recommending cranberry juice. And others, they rely on urologists like myself to make sure there's nothing scary going on. But I really want to get an idea of what our office, what our some of our primary cares think. So if you can give me, we're going to do a poll. If you can give me some feedback. Does one specifically relate to you? Let us know. we'll wait for about 50% feedback and we'll go from there. How's that, Jody?
Yeah, we are at 50% and results
Okay,
are shared.
interesting. Okay. So I guess it seems, let's see, which one was it? Oh, so I guess 40% coming in at, is it recommending cleaning from front to back? Very interesting. Okay. And cranberry juice. So we'll talk about that. We'll talk about cranberries obviously in this talk. So thank you for that. Okay. So let's move on. So I'm Dr. Inoyatov. I work with Z Urology. We are a private practice with 10 urologists in South Florida. We've been in practice for about 20 years. We service a very large area, about 60,000 patients treated annually by us and 30 Florida communities. So I love what I do. I see a lot of recurrent UTIs and I'm very proud of it because, it's the best feeling when you can get someone UTI free. Just a disclosure, UTIVA asked me to be a speaker for them. Very happy to do that. And here are my objectives. So I want to distinguish and teach you how to distinguish asymptomatic bacteriuria from UTIs. We're going to learn how to triage recurrent uncomplicated UTIs versus complicated ones. We're going to understand my 5 pillars of recurrent UTI prevention. And I'm going to teach you how to empower your patients through their journey. So UTIs by the number. I mean, this is the number one infection that leads to an antibiotic prescription. 25% of adult sepsis cases originate from the GU tract caused by complicated UTIs. And I always say, follow the money. $2 billion are spent annually in the ED for UTI treatment. I mean, that's just incredible. When I look at UTI management, it's easy to live in a vacuum thinking you're the only doctor taking care of your patient, but really it's a team approach. So we have the primary care physician, the urologist, myself. Our women are going to see their OBGYNs typically before they see me. Unfortunately, some of them end up in the emergency room or urgent care. And obviously, for the complicated cases, I usually rely on my infectious disease colleagues. But whenever you feel like you're the only one taking care of this, remember this is a team approach. For me, I fall back on the AUA, American Urologic Association guidelines, which were recently updated in 2025. The first step in the management of UTIs, I know this is a busy slide, but essentially the takeaway from this is that for every suspected UTI episode, we should obtain a urine culture prior to treatment. And there's really no need for imaging or cystoscopy in the routine index patients. So that's why I believe our primary cares are the first line in the management of these patients. We don't need to do expensive testing. We don't need to perform invasive testing. It's really starting with the urine culture. The workup, obtain a good history and physical, assess their risk factors. Here are some of them that are listed. What we're looking for, are they immunocompromised? Is there any neurologic history? Are they voiding well? Are they emptying their bladder or is there obstruction? In our male patients, you want to assess the prostate. Is there BPH? In our female patients, we want to look for pelvic organ prolapse. And again, most of our patients will actually not have these risk factors, but I think it's important. We want to obtain our urine analysis and culture, and we want to look for red flag symptoms. So fevers, what are they are there comorbid states, diabetes, and obviously blood in the urine, hematuria. So it's one of the changes most recently when we look at the infectious disease guidelines, they've actually switched over their classification of what used to be uncomplicated UTIs to what now is defined as an uncomplicated UTI. So previously, we were looking at uncomplicated UTIs as acute cystitis in afebrile, non-pregnant, premenopausal women with no diabetes or anatomical abnormalities. Then there was acute pyelonephritis, and finally everything else was complicated UTIs, as well as UTIs in men were considered complicated. The new classification essentially now says that it's more defined to the bladder. So an uncomplicated UTI is an infection confined to the bladder in both men and women. They simplified it. Complicated UTIs are beyond the bladder in both men and women. So pyelonephritis, febrile UTIs, caudities, and prostatitis. When we look at this, as a localized versus systemic infection, localized, you're seeing these patients in your clinic. So dysuria, urgency, frequency, there's new incontinence, maybe there's purulence. Systemic UTI symptoms, we've seen this before, especially in the emergency room. Fevers, delirium in our older patients, hypotension, tachycardia, sepsis. I want to go through a case with you. So an 82-year-old female in assisted living, her son is very worried and is calling you about her recurrent UTIs. Her symptoms, slight confusion, headaches, really nothing else. She's afebrile, but multiple repeat cultures show 100,000 of E. coli. She has no urinary symptoms. She's able to communicate. So my question to the audience, is this a UTI or asymptomatic bacteria? We'll wait for about a 50% response rate. All right. So, wow, interesting. So, about a third said this is a UTI, and two-thirds have said that this is asymptomatic bacteria. So, this, in fact, is asymptomatic bacteria. So she really didn't have classic UTI symptoms like I listed before. And while her culture is growing out bacteria, we really should not treat this patient. There's actually more harm than good. So the AUA guidelines state that we should omit surveillance urine testing in asymptomatic patients. We should not treat these patients. Now, there are subsets that we should treat, such as pregnant women or patients undergoing procedures, especially those that undergo GU procedures. A UTI is symptoms plus a positive culture. So recurrent UTIs are 2 in 6 months or greater, or 3 or more in a year. And again, symptoms matter because if they're not present, then it's asymptomatic bacteria. So dysuria, frequency, urgency, pelvic pain, pressure, fevers, or chills. First line antibiotics, when we go by the guidelines, are macrobid for 5 days, Bactrim for 3 days, or fosfomycin for 1 day, 1 dose. It comes in as a powder. However, what we've seen is more resistance, unfortunately, because we're over prescribing antibiotics. So one of the things I recommend is checking an antibiogram. These could be found at your local hospital. Some of the commercial labs that you work with, you can actually request that information. Or if you work with an infectious disease team in the community, they can actually offer that for you. And here's, I'm not sure how much you can see, but here is an example of antibiograms. They essentially list the different bacteria, they list the percent susceptibility, and the number of strains that were tested in your community. So if you really want to tailor empiric antibiotic treatment, you should request one. What's the differential diagnosis? This is why urine analysis and cultures matter, because it could be so many other things. Overactive bladder, I see this every day. Bladder cancer, especially carcinoma in situ, so CIS, can mimic a UTI. In fact, when we look inside these patients' bladders, they appear like cystitis, but when they get biopsied, unfortunately, it's bladder cancer. A bladder or ureteral stone can mimic it. Some patients come with mixed incontinence, so they have both urgency and stress. Interstitial cystitis, again, this is a rare, diagnosis, but it can happen, and it is our job to figure out if it's a UTI. So urine culture really helps me here. In our younger patients, STIs. In our older patients, atrophic vaginitis. We'll talk about that. Male patients, prostatitis. This is a classic, mimicker of UTIs. However, if we miss it, antibiotics can change for these patients, and they usually don't get better with the 3 antibiotics that I previously used. And strictures, again, this is something we probably see more often. One of the things I want to offer you is an office framework. How can we make it easier for you? So one of the things I recommend is establishing something we do here at Z Urology, a urine drop-off pathway. Instead of bulking your office with several patients who come in and see you and then drop off a urine sample, instead you can make it easy. Have them come in if they're symptomatic. Have your office staff just make it a visit where they drop off a urine sample. They don't need to see a provider. obviously, if they're really symptomatic, they should probably see someone, or if you have a an APP, they can see. But usually, they just want to know if they have a UTI. So typically, we get a urine test, and we really prioritize, patients who are symptomatic, those that are pregnant or undergoing procedures. This has helped our office substantially because we're essentially decreasing office visits from these patients and instead getting the urine culture. And if it's positive, we send an antibiotic. And if it's negative, we ask them to come back so we can investigate further. We really don't use dipsticks in the office, and we discourage our patients doing at home exams. I think everyone here would agree that the tests are not always reliable and we get mixed responses. And I introduce preventative measures at the first visit. My goal is to shift their thinking away from antibiotics and how do I prevent these? When do you refer to us, the urologist? You can always refer to us. We appreciate it, but really it's for the red flag symptoms. So gross hematuria, recurrent pyelonephritis, kidney stones or bladder stones, patients who are not emptying their bladders, and neurogenic bladders associated with spinal cord injury. Obviously, refractory recurrent UTIs, despite everything we're going to talk about. So I want to shift my talk to the 5 pillars of UTI prevention. So these pillars were actually introduced by my former chief resident, Dr. Wei Li. I want to give him a shout out. He presented this at the AUA conference in 2024, where his team essentially, they had 5 interventions that were non-antibiotic, and they looked at their data, and it was pretty compelling. That's why I actually adopted this in my practice. Across all their patients, both pre and postmenopausal, they were able to show a substantial decrease in UTI rates by implementing these 5 pillars. So we're going to go through one of them, or each of them, one by one. So fluid intake. So I recommend to all of my patients, especially if their heart is healthy, to increase their fluid intake to about 2 to 2.5 liters a day. Now, that's not easy. This study showed if we do it with 1.5 liters a day, we still see improvement in UTI rates. So this was a study published in 2018 in JAMA, Internal Medicine, where they took about 140 women and they increased their fluid intake versus the control group to about 1.5 liters a day. And they showed a significant reduction in recurrent cystitis episodes. Again, this was obviously a very healthy young population, premenopausal women, but I still think it says a lot that increasing our water intake will flush these bacteria out of your system, and it's a low risk intervention. So I think that's the first pillar. The second pillar is looking at constipation. I can't begin to explain how many of our patients present with constipation or some type of bowel dysfunction and have recurrent UTIs. We know constipation is associated with pelvic floor dysfunction. Many of these patients have a history of pediatric bladder and bowel dysfunction. That's really where the research is rich in this area. There's a lot of literature that says in patients with bladder and bowel dysfunction in the pediatric community, if we fix their bowels, usually their urinary issues, including UTIs, decrease significantly. And the idea is that this large stool burden is impairing bladder emptying, and we see a reservoir of E. coli in that stool that's transferring to the bladder, especially in women. My thinking is if you're not asking about bowel habits, you're missing a part of the recurrent UTI work. And the way I look at this relationship is it's really all connected. So you have recurrent UTIs, and in those patients, you typically have some type of pelvic floor dysfunction. And those patients who have recurrent UTIs, it actually causes worsening dysuria. When they feel that pelvic pain, they don't want to empty their bladder. So it's a vicious cycle. And that then causes worsening constipation. So how do we break this cycle for our patients? What I recommend is attack the things you can attack. So for constipation, fiber, increasing that, putting them on a bowel regimen. I typically do that myself, something like daily Miralax, and hydrating. Obviously, when you need to, you refer to your GI colleagues. Sometimes these patients need colonoscopies. For pelvic floor dysfunction, I work very closely with my pelvic floor therapists. I always explain to my patient, there's physical therapists and then there's pelvic floor therapists. These are people who are specialized in a form of physical therapy that focuses on learning how to improve your pelvic floor muscles and either relax them or strengthen them. But I think using this approach, you actually can improve their recurrent UTI rates. Cranberry supplements. So I really want to take time on this. So the AUA in their latest guidelines has said that clinicians should offer cranberries as an option for prophylaxis for women recurrent UTIs. So there's grade B evidence that we really should start putting our patients on cranberry supplements and not just cranberry juice. I want to take a poll at this time. How many of you have prescribed cranberry supplements for UTIs? All right, let's take a look. I'm interested. So a small subset have never really heard about them, but we're pretty split. Interesting, right? So let's take a look. So cranberry supplements. So we know that Utiva is just one example, my favorite for my patients, but how do they work? So there's an active ingredient, these proanthocyanidins. They're essentially these little chemicals, we refer to them as packs, that block the fimbriae from the bacteria connecting to our bladder wall. So we've looked at this and we know that 36 milligrams is the recommended and verified dosage that we need for this to make a difference. And I truly believe not all cranberry supplements are equal. Many of the ones that are on the market have impurities. They may use different parts of the cranberry, but they're not really extracting the pack that you need. Utiva was actually, it's measured by the DMAC A2 method using a reagent that verifies and is the preferred way to measure packs. So this was, again, verified to have 36 milligrams of pack. And that's what I recommend to my patients. In fact, for many of my patients, I always tell them if you are having early UTI symptoms, if we could catch this early, taking 2 pills a day has actually, at least anecdotally for my patients, improved their UTIs from getting worse. Obviously, this doesn't replace antibiotics when you're having a UTI, but as a daily prevention, I think it's an excellent method for our patients. Moving on to probiotics. So there's oral probiotics, there's vaginal probiotics. I prefer vaginal probiotics. These are, again, so direct to consumer. You don't need a prescription. This was a study that looked at the various forms of probiotics. So they randomized 174 premenopausal women with recurrent UTIs for 4 months. Four groups, including placebo, oral probiotic group, a vaginal probiotic group, and a combination with oral and vaginal. And what they found is the group that really made the most significant change in recurrent UTI rates was the combination, oral and vaginal. However, there was really no statistical difference between vaginal. So the way I see this is if you're going to recommend anything for your patient, start with vaginal. If they're really motivated, oral and vaginal works best. If there's really a difficulty getting the vaginal probiotic, then I think giving them oral is still better than nothing. Moving on, so for our perimenopausal and postmenopausal women, the AUA recommends the use of vaginal estrase in these women. The idea is that it restores vaginal flora, the epithelial, and it really balances the bacteria, so the lactobacilli, and it decreases colonization. It also has improvement and benefits with moisture, with comfort for our women, and sexual function. Just looking at dosing, I typically recommend the cream about 1 gram daily. So the way I explain is you're going to do it 1 gram daily for 2 weeks and then twice a week thereafter for maintenance. So I always say choose 2 days, Monday and Friday, and you're going to do that for maintenance. And before we got to give it about 2, 3, even 4 months before you see benefits. But here are some of the benefits. So it restores moisture, it strengthens the vaginal tissue, it supports urinary health by decreasing UTIs, and even discomfort goes away. So itching, burning, dryness, and it protects vaginal health. So it comes in many forms. Again, most of my patients prefer the vaginal cream. However, I think, for example, the vaginal ring on the lower right side, this is excellent for our elderly women who have difficulty applying it. You can change that out every 90 days. The other two are suppositories, again, very useful for our patients who want to avoid using the cream. I want to emphasize this is not the same as systemic hormone replacement therapy. This is safe, it's effective with minimal side effects. I know that, estrogen has been in the news with the FDA, but in general, if you're really concerned, especially let's say they have a history of estrogen positive breast cancer, I usually team up with a gynecologist or an oncologist, and they're most of the time they're okay, especially even in survivors. There's really no data to say that this is something dangerous to give to our patients. The data shows it's about a 50% reduction in recurrent UTI rates if we add this to the regimen. So it's the best and probably most studied intervention that we have in the guidelines. So just looking at these two populations, premenopausal are younger women, postmenopausal. So when I think about a premenopausal patient, I'm managing their risk factors. So pre and post-coital voiding, I recommend that to all of my patients. Spermicides, I try to avoid them. If there's going to be lubricant used, water-based. Most of my younger patients, they're not really drinking water. Teachers, for example, I always say they have difficult bladders because they're waiting all day to urinate. They have, kids running around. So I try to tell them to do time voiding, avoid constipation, add cranberry supplements, and rarely I'll go on post-coital antibiotics. These are really for refractory cases. So if you could think of macrobid, or macrodantin, 50 milligrams daily, typically I would give it to them just post-coital, so after having sex. For our postmenopausal women, my goal is to restore their vaginal flora using estrace, vaginal probiotics. I'm really looking for pelvic organ prolapse. I'm looking for constipation. Sometimes they're related, and especially with incomplete emptying, that's typically related to pelvic organ prolapse. So I'm looking for those risk factors on exam. Our older patients, they're having difficulty to increase their hydration. This is typically a reason why they show up in the emergency room, dehydration. Especially here in Florida, it's so hot at times that is just a very simple thing that I can improve for them. And I try to avoid prophylactic antibiotics in these patients. We know that this has led to resistance. There's side effects, for example, giving macrobid, nitrofurantoin daily, especially if you're doing it for 6 months at a time, can cause interstitial fibrosis. So that's not something that I prefer. Instead, what I've used is methenamine, so Hiprex. So this is a non-antibiotic preventative option. The mechanism of action is it's converted to formaldehyde, so it's bacteria static in acidic urine, typically with a goal of a pH of 5.5. The way I dose it is about 1 gram twice daily, and my goal is to wean it off over 6 months. And I'm really careful with this. I want to avoid this in renal or hepatic insufficiency patients. It can actually cause crystals in their urine. So again, I'm very selective. This is for refractory patients. So I just want to walk you through a case. This is someone that would show up in my office, a 67-year-old female with recurrent UTIs. She comes to my office after her third UTI. These are all culture proven. She has the symptoms, frequency, urgency, and dysuria. On exam, she has atrophic vaginitis, dryness. My history, I learned that she has chronic constipation. She goes every 4 to 5 days and she's straining. She drinks coffee in the morning, tea at night, no other beverages. So what did I do for her? I offered her cranberry supplements, vaginal probiotics. Constipation was treated with daily Miralax and fiber. I increased her water intake to about 2.5 liters daily, and I added vaginal estrus. Again, twice daily for 2 weeks and twice a week thereafter. And most of my patients over the next 3 to 6 months, no further UTIs. And that is really the goal here. So how do we empower our patients? So I have this conversation. Many of them come to me with this stigma that it's their fault. They're embarrassed, they're shy. They're really at their wits' end. So I tell them that this is a common problem. They're not the only ones going through this, and they're in the right place. And I explain to them that personal hygiene, they can take 2 showers a day, they can take 5 showers a day. It's not really going to make a difference. They're not doing this to themselves. They just have that, misfortune of dealing with this. Most of the patients actually, unfortunately, don't come in with this problem. They go to urgent cares. They just try to, see a patient over the internet now, televisit docs. They're trying to just get rid of the problem as quickly as possible, but it keeps showing back up. So I think it takes courage for a patient to come in and present like this. My goal is to shift their attention away from antibiotics. I always tell them if you're really trying to work with me, let's stop talking about antibiotics and shifting towards prevention using those 5 pillars. And you want to work with them because again, if you educate them and you teach them about recurrent UTIs and how to prevent them, they will always come back happy. They'll get rid of this problem. They'll focus on other parts of their life and their quality of life will improve. So in conclusion, urine culture is key. I think I've shown you that the differential for these symptoms is large. Some of them are dangerous, like we can be missing bladder cancer. Other times, it is a urine infection. But without a urine culture, we can't even begin to have this conversation. Asymptomatic bacteriuria is overtreated, and I think that we need to be selective. Obviously, in pregnant patients and those undergoing procedures, we should treat them. But in our patient who's coming from the assisted living facility with no urinary symptoms, they're able to communicate. We really should be careful because there are risks, including C. diff and antibiotic resistance. So preventative measures, they're supported by the guidelines. So this is not, voodoo medicine. This is actually guideline and literature supported interventions. I think we really should focus on that. Daily cranberry supplements, you should really verify what you're using. Utiva has verified their product. 36 milligrams of pack is what your patient should be looking for. If that's nowhere on the label, then really they're just unfortunately wasting their money. And again, it is our job to empower and educate our patients because they're going to find their information elsewhere. They're going to be embarrassed. They're going to blame themselves. This is not their fault, and we can really make this better for them. Thank you, everybody. I hope that wasn't too long, but if there's any questions, I'd love to open up the conversation.
That wasn't too long at all. It's perfect timing because we have a ton of questions.
Great.
So we can get started if you're good to go.
Sure.
All right. So a few questions came about regarding that first case study with the female patient who was confused. So the questions came about regarding like if she's confused, isn't there a risk to not treat her, with confusion being, one of like a symptom? And then some people made comments like well, it wasn't made clear that it was an acute confusion. So could you help kind of answer that one?
Right, right. Of course. No, that's a good question. So look, I think we do have to be obviously patient specific. So if the goal of that was if they're able to communicate and it's not an acute change from their baseline, I think that we shouldn't be overtreating. All of her cultures are coming back with this bacteria. Most of these patients who present to me, they've been treated several times. Their confusion is not changing. I think that patient deserves a cognitive workup. I think that if we've already treated this several times, with several cultures, and they keep coming back with the same bacteria, we obviously are not, treating that patient correctly. So my goal is to, again, if there's no urinary symptoms and they're able to communicate that they're having no urinary symptoms, we really shouldn't focus on a UTI. If there's even mild UTI symptoms, I think it's worth treating that first time. But if we're really not seeing any changes in cognitive function, I don't think I think we're overdoing it.
Okay. Thank you. That was helpful. Okay, next question here. Is taking macrobid every time a postmenopausal patient has intercourse Still recommended for females with a history of severe cystitis, resulting in incontinence, pain, and hematuria.
So I think postcoital antibiotics are a method for select patients. I think postcoital is acceptable, especially if some of those other preventative measures haven't helped. The idea would be that should be really our last resort. Again, I prefer postcoital antibiotics as opposed to something like a daily antibiotic prophylaxis. I think that comes obviously with more risks, but I think that's still acceptable.
Okay, so you made a point that you would recommend increasing fluids if the patient's heart is healthy. How do you, like, what would you do if the patient has CHF? Like,
So I
how
would
would
probably,
you?
yeah, no, I deal with this very often. I would advise them to hydrate to their limit. That's usually suggested by the cardiologist. So if they have a fluid limit, I would hydrate to them up to that point. Um, Obviously, look, we have to be careful. I usually will look at their cardiology records. I'll speak to the family who typically knows that limit. But I would hydrate to their limit. It's very impressive how many of our patients don't even hydrate to half of that. So I think there is some room, but obviously we don't want to put them in acute failure.
Thank you. Hey, Dr. I, do you mind stopping the share just so
Oh,
everyone
of
can
course.
see
Yeah,
you
yeah, yeah.
better?
Sorry.
Thank you. No, no
Okay.
worries.
Yeah.
Okay, so then next question here. It's a bit of a case. Just bear with me as I read it.
Sure.
So, in a patient that had symptoms, prescribed empiric nitrofurantoin. Always have trouble saying this one. Prescribed empiric nitrofurantoin. 3 days
Perfect. Yeah.
later, culture returns negative. I am told by other providers in practice to have the patient complete the antibiotic if symptoms are improving, even though the culture is negative. Is there truth to this approach?
So what I would want to know in that case, did they start the antibiotics before or after the culture? Because that makes a huge difference, right? Um, Typically, we do want our patients finishing antibiotics, especially if they've had the symptoms and if maybe they're seeing an improvement. But I think the most important thing is when did they start the antibiotic relative to that urine culture? Because sometimes only a single dose could make that urine culture come back negative. The other thing we can consider in this case, especially when it's a confusing case, is something called PCR testing. So looking at the DNA. And we have access to that. It's a urine test that you send out for PCR.
Okay. A few questions came up regarding the timing of taking the cranberry supplements or like the cranberry packs, the 36 packs. So there's a couple questions. I'm just trying to merge them into one. But basically, they're asking once the UTI is treated, should they continue taking these? And another question regarding that was, um, I guess the person who asked, they've been told that ongoing cranberry supplements can cause irritation of the bladder.
So just the second part of the question, I haven't seen ongoing cranberry supplementation cause irritation of the bladder. Luckily, I'd be interested in hearing more about that. But in terms of you're asking timing and long term, I see it as a long term solution. Obviously, if they want to take breaks or little vacations from that, that's fine. But the idea is that you have now received this diagnosis of recurrent UTIs, and we really need to make a substantial change. So, including those five pillars, one of them being cranberry supplements, I see it as a long-term solution. So, we're talking about months instead of weeks. And so, at a certain point, let's say 6 months, if they're stable, they can get off of that. But it really will make a difference the longer they're on it.
Yeah, we see that time and time again in our feedback from our patients too. Okay, let's see. Okay, I have a young lady with urinary symptoms who was treated in urgent care with Cipro 250 milligrams BID 3 days. The symptoms do not improve, but the urine culture is negative. What can we do next?
So, this is an interesting case. So, for that patient, what I would do, a couple of things. Again, um, we would want to know the timing of the urine culture based on when she got the Cipro. That's number one. Number two, this is a good patient population where we would want to test for urea plasma, mycoplasma. These are other, almost like STI tests. that I'd want to test. Typically, they improve with doxycycline. So sometimes I empirically offer them that instead.
Okay, thank you. There are quite a few questions about the use of cran 36 milligrams, the PAX cranberry for postmenopausal women.
Um, I, I give it to postmenopausal women. I don't really, that's not a difference between pre or post. I think it works in both populations. I think that you're going to see probably a more robust improvement in your younger women because if you don't really change the vaginal flora with estrogen use, the cranberry supplements, I don't think they'll work as well. So I see it as like a symbiotic relation. You really want to do both.
Okay, great. There's a lot of questions on probiotics. Um, the logic behind using probiotics, are there any specific strains that you recommend?
So there is a few that have been tested. Any lactobacilli um, are, are are really the ones that are looked at and studied the most. There's a few vaginal. I see a few questions about which one I prefer. So Evi has one. Again, you can actually get this. Your patients can get them off Amazon. Direct to consumer. Clairvy is another one. These are all vaginal. They appear essentially as suppositories. The idea there is that we believe the vaginal flora, for whatever reason, we have what we call the good bacteria and the bad bacteria. Essentially, there's a disbalance, and what we're trying to restore is a balanced bacterial load in these patients. So they're safe, they're effective. I don't really see any risks in these patients, but I don't really know about any obvious contraindications. At least I haven't seen any.
Okay. Let's see here. When would you consider 2 doses of fosfomycin?
So that's an interesting question. So typically one is enough, at least when you have a uncomplicated patient. I would say I give more phosphomycin. Again, it's every 3 days, so you don't want to dose it back to back. So it's one dose every 3 days. I typically do that for patients that are refractory. In other words, we treated it once, they come back, they have classic symptoms and a urine culture that's proven. So I would give it to them. My idea is give it to them for 3 total doses across 9 days. Those are, again, for cases that are more difficult for male patients and for patients that are really just not responding to that initial dose.
Okay. Any tips or tricks to convince patients to drink more water?
Yeah, so that's a good question. So flavor
Mhm.
it. Again, I'm not trying to add more sugar to their diet, but I think just there's so many new flavor. There's some that come with minerals. So flavoring it, sparkling water is just as good. I think that timing. So there's actually it's interesting. There's a new device on Amazon where it essentially Bluetooths with your phone. It's a water bottle and it reminds you, it texts you, hey, you're behind on fluid intake. That has improved my patient's fluid intake. So I think you just have to make it fun for them. My goal, though, essentially is not to have them taking coffee and tea as their only beverage because those are bladder irritants, and the caffeine load will only irritate their pelvis.
Okay. And they dehydrate, right?
Absolutely, yeah.
All right. Let's see here. Okay, if somebody is on antibiotic prophylaxis and they grow a resistant organism, i.e., ESBL, is there any utility in continuing their home prophylactic antibiotics such as Septra, Keflex, etc.?
So first, it would depend on reviewing that, the sensitivity profile on that culture, because if it's an obvious resistant drug and we're still giving to them, I see no utility. Those are the few patients where I lean on my infectious disease colleagues because, despite everything you're trying to do, again, I'm going to assume we've done everything. The vaginal, if postmenopausal vaginal estrogen, we've done everything. We increased their hydration. They have no pelvic floor dysfunction or emptying issues and there's no catheter in them, but they're still resistant, I think we need infectious disease input at that point.
Okay. Okay, this question involves a wheelchair-bound elderly patient who calls frequently for dysuria and polyuria, asking for prescriptions of an antibiotic. I would appreciate your comments about a recommended approach.
Of course. So that's a patient that we are often referred. We see them in our office. So for that patient, it might be difficult, right, to get a urine culture. It might be difficult for them to come in. That's a patient who deserves to see a urologist. And oftentimes what we do is we get a catheter or specimen because that will really tell me, is this a true UTI or is it more of like a vaginal infection? Because the symptoms could be very similar. So that's a patient I would refer to urology and then consider a urine culture.
Okay. If a urinalysis comes back as bacteria 4 plus, but with CNS of doubtful significance, the patient is symptomatic, would you suggest treating them?
That's a tough case. So I would, but I'd want to investigate further. You know, obviously there's something there, but we're not getting a good feedback from our urine culture. So I'd either repeat the urine culture, or in that case, PCR testing would probably help us as well.
Okay. Would you ever suggest vaginal estrogen for younger female patients if other measures do not work?
Vaginal. Can you repeat that? I'm sorry.
Yeah, no worries. Would you ever suggest vaginal estrogen for younger female patients if other measures aren't working for obviously for UTI?
So there is some data to support that even in younger patients we can give them. If they're not perimenopausal or getting close to menopause, I personally probably wouldn't. But it is being looked at. I know that there are female urologists that are starting to do that actually.
Okay, we have a few questions about D-Manos. Curious to know if you use it in your practice, if you have any thoughts on it.
Yes, so Dean Manos, there's been some evidence to show that it does not make a difference. So I've recently used it less. The evidence is still questionable. I prefer cranberry supplements. A lot of my colleagues, they're doing both. So Dean Manos with cranberries. Um, I don't think it harms the patient. I just don't believe that on its own will make a big difference. So I don't use it on its own. I like to add cranberry supplements to it. If my patient's already on it, I just tell them to continue it, but I never would do it on its own.
Okay, thank you. Let's see here. Okay, we still have some time, so I think we can get through majority of the questions, which is great.
Great.
Um, okay, what do you think about pharmacists giving antibiotics for UTI symptoms without cultures? I don't know what the how it is in Florida, but here in Canada, our pharmacists have that ability for non-complicated UTIs.
So that's interesting. So based on my talk, that would go against what I believe in because if we don't have a urine culture, I think in your younger patient who's coming in with obvious cystitis-like symptoms, I think that's okay. But as an ongoing recurrent thing, I probably wouldn't support that practice because at the end of the day, that patient really deserves to be evaluated, examined, look for their risk factors. So I think it does help probably. Some of our patients, but overall, I don't think it's best practice.
What if that patient, because I know there's a lot of pharmacists who have logged in tonight. What if that patient, okay, so the pharmacist recommends that they wait to see their doctor. Would you recommend that they give them any sort of symptom relief or anything in the meantime? How can
Yeah.
they help them?
No, I think that's fair. I think, in fact, look, what I would love to say is if we get a urine culture, we can do more for that patient, right? We could start prophylactic antibiotic. We can give them, an azo product or something to cool off, like Pyridium, to cool off their bladder for symptoms. But I think like a one-time thing is fine. If this is a recurrent thing, that's where I think I have a problem with that.
Okay, that's fair. Um, how do you collect a clean urine sample in an elderly woman with incontinence and frailty? Frailty.
Yeah, so if that patient can make it into our office, our staff is trained to do what's called like a straight cath sample, because I think that would give you the best idea of what's really growing in their bladder. So that's how I would guide that patient.
Okay. I saw a patient today, negative leukoesterase and nitrate on urine dipstick, but she has symptoms. I sent the urine for culture anyway and gave her macrobid. Do you have any comments?
I think if her symptoms are classic UTI symptoms, despite a UA that doesn't show anything, I'd want to see what that urine culture shows. But I think that's fair, especially if the patient's suffering. I would say that we don't have to wait. And macrobid is a pretty safe antibiotic for short-term use, so I don't think there was harm there. But if she has classic UTI symptoms, I think that's fair practice. But we'd want to see what that culture shows.
Dr. I, do you see any pediatric patients, you or any of your colleagues in your clinic?
My colleagues do see pediatric. I myself start seeing patients usually over the age of 17.
Okay, I asked because there are a couple questions here on whether the packs are, if you or your colleagues offer them to patients or to pediatric
Yeah.
patients.
There's from what I understand, there's really no danger in that. But I think pediatric patients deserve a completely different workup. Again, in pediatric patients, I'm thinking more about bladder bowel dysfunction, maybe reflux. But I would probably wait on the packs until we get a true pediatric urology workup.
Okay. It sounds like there is a challenge where patients really, I'm just scanning the questions where some patients are just really pushing for a script. They do not want to leave the office without a
I
script.
I am completely understanding of that. I think that in a world where we practice medicine the way I had it in my slides, you can't just get a script. But in reality, I myself am guilty of just going back and forth with the patient and saying, fine, this time we can give you a script. But your goal, again, the overall goal, the overarching goal is to shift their attention away from antibiotics and try to understand and prevent future infections.
Okay. Let me see. Just a couple more questions here. Okay, so you mentioned azo for symptom relief. I was hoping maybe you could help clarify this question. How often can azo be used for recurrent UTIs if they get the UTIs frequently? I think they're referring to
Yes,
the symptom relief here.
right. I think so. I think this is based off the idea. So, pyridium, which is essentially a stronger form of azo, is often we're worried about giving it to patients with renal insufficiency, especially for more than 2 or 3 days at a time. I see azo very similarly. Essentially, in the first 3 days, it's safe to give it to our patients. There's actually data that even longer is safer. But I would probably, in my own practice, I give it to them in the first 2 to 3 days of their UTI. That way, the antibiotic starts and kicks in, and their symptoms improve.
Okay. I think we've covered a good amount of the questions. And so I don't want it to become redundant. I think you've answered most of them in some shape or form. But before we say our goodbyes, is there anything, because most people here on the call are primary care.
Yeah.
Is there any words of, I don't know, advice and wisdom you can leave them with? Because wait times can be long, for them to get their patients in to see a specialist. So yeah, anything you wanna say?
Yeah, sure. So I think, look, first of all, I want to thank all the primary cares out there. I think what you do is incredible for our patients. I think that UTIs are a challenging problem for all of us. The way I stress to you is make it as easy for your patients to drop off a sample. Even if it's not an official visit, I still believe that getting that piece of information will shift the whole visit. And I think if you can do that for your patients, just make it as easy for them to collect a sample, either some type of way to send a script to the lab or have it drop off in the office. Once you get it, make it easy for them, you will see an improved rate of urine cultures, and then that will shift your practice into really managing these UTIs for what they are. And if they're not UTIs, that's the time to refer to urology, infectious diseases, etc. But I think just try to make it easier for your patients, and it'll go a long way.
Awesome. Thank you so much. I just wanted to
Thank you.
say, definitely enjoyed the presentation. You had a great breadth of questions. So yeah, thank you so much for your time,
Thank you.
for your expertise.
Thanks for joining, guys. Thank you.
Of course, take care.